Federal rules restrict an airline pilot to a flight maximum of 8 hours if he or she is piloting the aircraft solo. This is because the human brain operates at peak performance for only so long. Minds and bodies tire and require rest. One term for handling highly technical and information-heavy tasks is cognitive load, a measure for the mental effort required for processing whatever you're dealing with at the time. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly with AHA Communications. Clinicians bring all of their skill, expertise, and mental firepower to bear on great patient care. But there are many aspects of care today that can derail or compete for their attention. In this AHA Safety Speaks series podcast, we explore ways to ease the cognitive load that many physicians and other caregivers face to allow them to focus on the most important job of treating patients. As today's guest, a retired professor of psychiatry at the University of Rochester Medical Center puts it, brainpower is a finite resource. We have to budget the expertise like we would money and allocate it in the right places.
Thanks, Tom. I'm Elisa Arispacochaga, AHA Vice President of Clinical Affairs and Workforce, and today I'm really excited to be joined by Dr. Michael Privitera, Professor Emeritus at the University of Rochester Medical Center, who is a leading researcher on the intersection of healthcare quality and safety with well-being and a good friend. Today's podcast is part of AHA's Patient Safety Initiative's Safety Speaks series. So, Mike, to get us started, tell me just a little bit about you and how you came to this work.
Sure, absolutely, Lisa. Good to see you. Basically, from the point of view of seeing many changes in healthcare and how we tend to get overwhelmed with the information explosion that we have and a lot of expectations, but without the adequate resources, really, to deal with them and the overload, basically. So trying to look for a science that would help us, would give us language. That's kind of how I came across human factors and ergonomics. And one of the things we talk about today is cognitive load.
Well, let's get into it. Let's start with that. Can you explain to me, because I didn't understand it before I heard you explain it, what do you mean by cognitive load and why is it particularly relevant for clinicians? You're a retired physician now, but why is this so important, particularly for our clinical colleagues?
Sure. Cognitive load is basically, it's kind of a measurement of mental effort that's required in processing whatever it is you're dealing with at the time. So it could be very simple to very complex. If you're in medicine and nursing, it tends to get very complex sometimes. So that would have a higher cognitive load than something that's very simple to deal with. And this all gets processed through a part of our brain called the working memory. And we only have kind of a short time to deal with it. So our working memories only gives us about 15 to 30 seconds to actually process something. So we easily can get over the limit to overload, and we've found workarounds around this, but that's why it becomes so important so we don't make a mistake. If your profession has really high cognitive load per se, you're higher risk for burnout. In a particular task, if the cognitive load is measured to be too high, the research shows that you're more likely for medical error. So it's very important.
So can you tell me a little bit about sort of the cognitive load? Can you dive in a little bit about how it works and what it really measures?
Sure. That's where I think human factors and understanding cognitive load can really help us out of the current predicament we're in with ever increasing expectations and basically technology really exploding and making it harder for us humans to adapt, right? The good news about cognitive load is there's the essential part, which is the intrinsic cognitive load. And that's basically the inherent difficulty. And how we present something really makes a difference about how much of that brain power we're using. So this research originally started in education. Dr. John Sweller in Australia was understanding the three parts of cognitive load. We talked about intrinsic. Germane is how much brain power is being used to make the mental model in your mind of what it is you're dealing with so you can store it into your long-term memory. Or if you come across a pattern, you just heard a patient's history, that sounds like congestive heart failure, and you're kind of downloading from the long-term memory back into working memory. And then you say, oh my gosh, that's the diagnosis here. So then extraneous cognitive load is where we have lots of opportunity. That's basically the waste that we could get rid of. What is it that we could remove by better design? And sometimes a lot of conflicting pieces of information or too much information, or we're trying to synthesize all these expectations. That's extraneous cognitive load. And it kind of pulls our brain power away from the task at hand that we either have to learn or do. So that's where our opportunity is. We can really work by understanding how to get rid of this extraneous cognitive load and actually be able to see this invisible thing that's getting in our way.
You've mentioned human factors and ergonomics a couple of times. Can you just dig in a little bit more on that as well? I want to make sure folks understand, what does that even mean?
Human factors and ergonomics is a science, really. It's embraced in many other professions, but not enough in healthcare. That's kind of our problem. So, in other words, astronauts, pilots, even if you're into simultaneous translating at the United Nations, they consider how much you're having to deal with cognitively, and they have mandatory breaks.
Mm.
But in healthcare, it's kind of like we're not seeing the human limitation. Even though you're boarded in 1, 2, or 3 things, if you stay up all night, or you have excessive cognitive load, you might make the error, and that board certification times 2 or 3 doesn't really protect you enough. It helps a little bit, but you're still in the human club is the point, and we're not addressing the human club parts of all this.
Absolutely. Absolutely. Every time I've tried to translate between English and Spanish, I'm very tired at the end, and I cannot do simultaneous translating. So
thank you for tuning in to this episode of Safety Speaks, the podcast series dedicated to patient safety, brought to you by the American Hospital Association. I'm Dr. Chris DiRienzo, the AHA's Chief Physician Executive and a champion of the AHA Patient Safety Initiative. AHA's Patient Safety Initiative is a collaborative, data-driven effort that lifts up the voices of individual hospitals and health systems into the national patient safety conversation. We strive to catalyze and connect healthcare professionals like you across America in your efforts to innovate and improve, and to bolster public trust in hospitals and health systems by helping you share your successes. For more information and to join the 1,500 other hospitals already involved, visit aha.org/patient safety, or click on the link in the podcast description. Stay tuned to hear more about the incredible work of members of the AHA's Patient Safety Initiative. Remember, together, we can make healthcare safer for everyone.
let's talk a little bit about some of the primary factors that really contribute to that high cognitive load in healthcare. Obviously, you talked a little bit about some of the challenges there. As a clinician, you're trying to bring disparate information together. But can you talk a little bit about how we sort of get in our own way, I guess, in terms of driving up that cognitive load in healthcare environments?
Really excellent point. And I hope that this kind of helps people to start to really see that this actually is a problem. It may be invisible to us, but it's a real problem that affects us: safety, well-being, quality, and our ability to sustain our career, actually. It comes from a lot of sources and basically high volume, too. Much of it is well-meaning, but it can be excessive and non-strategic. And sometimes it comes in the form of what we think might be patient safety initiatives or regulations. And they might, the way they're designed, backfire in purpose. A good example that comes to mind a lot in electronic medical record that we deal with is the best practice alert or pop-up. You realize that's guaranteed to derail what you're thinking about at the time. But yet it's woven in as a guardrail or a protective factor or to remind you not to forget about something. But if you don't know where that clinician is in their thinking process, their cognitive flow, they might be at the point after they've seen their patient, they're in differential diagnosis. Well, they have these symptoms. What might it be? If you derail somebody right there, they have anywhere from about a 20 to 40% chance that they may not get back to the material they're thinking about, plus the loss. So in other words, what we're doing, well-intended, but it can take up extra brain power to get back on track, and you may actually lose info. In healthcare, we have multiple regulators. We have multiple sources of authority, or the payers. You have to do this, that, and the other to get paid. So we have multiple sources, and trying to reconcile those different things, sometimes if they're directly passed down, coming through the C-suite directly to the clinicians that have to do something, that's a lot of brain power you're trying to reconcile, and it takes away from patient care application. I guess the whole message here is this is a finite resource. And the more we know about it, we have to budget the expertise of their brain power like we would money and allocate it in the right places strategically. So that's the hope of this science. The more we know about it, we can understand how we have to strategically allocate it.
I'm fascinated by this, and so much I think about how much I get when someone interrupts me when I'm in the middle of writing something, and the amount of time it takes you to get back to where you were.
Right.
I don't think I had actually ever thought about that. But yeah, if you're constantly being assaulted by pop-ups, whether they're best practice alerts or emails, it
Right.
can disrupt your thinking. So let's talk about some strategies that are helpful. We've sort of, defined where the challenge is. What are those effective ways of managing cognitive load with the healthcare workforce so that we can appropriately budget that very finite resource of their ability to think through a problem?
That's a really great question. And a lot of this is in process, in the works. So it's probably going to keep evolving over time. But we have one mantra to think about. Don't make them think more than they necessarily have to. If you can keep that in mind, extra stuff, if you can get to the point, concise, whatever. But standardization helps. If you allow a certain wiggle room for, the exceptions that are needed, what we call aligned autonomy, it's still following the strategic plan of the institution, but a little bit of room where specific things come on. Learning some of the points like consolidating information together. The concept is called split attention. So split attention is the greater the amount of time between two pieces of information or is space, either one, it makes it harder to see those two pieces of information as related and being able to put into your long-term memory that they're related. So put things together that are related. Process coupling is another example of that. If there's two types of processes, try to get them closer together. That saves cognitive load. Some of the things we do naturally, like dashboards, help us. Cross-comparative charts, so we can work within that 15 to 30 seconds of working memory. Redundancy, we talk about in engineering as having two systems. That's like in the airlines industry, a backup set of brakes for the plane if the one set doesn't work. That's redundancy. But in information, redundancy can backfire. So trying to keep it to one source of information where possible. Satisficing is a term that's from economics. It's basically satisfactory and sufficient to do the job. But in everyday things, think of satisficing. Is it good enough to do the job? It's a decision-making strategy.
I understand. Yeah, it's one that I struggle with. Understanding a way to, is it good enough to do what needs to be done? And where are the places where that extra energy can help where it's really needed? What you're saying is really being very strategic and thinking about ways to really tighten down on where that finite resource is being used.
Yeah.
Seems like it, can last forever, but clearly it can't. I know one of our earliest interactions was one of your great papers on executive function and how quickly that deteriorates when you are tired or you're having a bad day or you don't feel you have control.
Oh, yeah, it does. It does. If you think about how some things are designed, like if a CEO, for example, might have somebody that's your first contact to get in towards his or her office. And so it protects their brain function for thinking of high-level decisions. So if we can do that for the everyday person, what are the things that we can get off their plate so they can think for the most critical thing, especially if we're thinking about healthcare?
Yeah.
Are we having enough protection of the lesser needed types of things, take that off their plate so they have that function for the high level? And the executive function goes if we're highly stressed.
Yeah.
It's one of the last things to develop in evolution for us as humans. So it's sensitive to setbacks easily. That's the irony. We're not bulletproof is the point.
Yeah, absolutely. So let's talk about an example where some of these interventions that you just laid out actually lead to improvement. I know you've done this work in your role at University of Rochester. How is this making measurable improvement in clinician well-being and patient safety?
Well, in terms of some of the examples, it's like the well-meaning aspects of mandatory education, for example. It was all meant for improving patient safety and quality. But since they're coming from different authorities, they added up in ways and trying to reconcile the different needs, understanding the quantity, no resource provided for doing them. For example, you had to do them and finding time for them somehow. All those things, when we took this on as our wellness committee, First thing we did is just list them all, put them all together, and all the sources they came from. And then we shared that together with a quality and safety office and an education office. And immediately, the first week, when they looked at everything, 20% were taken right off. So 20% went away, to the gratefulness of most of the clinicians, realizing that so many things accumulated over time, they weren't kind of monitored enough.
Yeah.
And that happens because they come from different offices. That's one. Just in the major measurement of well-being, what we used a well-being index in 2018, and 3 years later, we reduced burnout by about 14%. By 2021, I love the term that you've told me about, Elisa. This was back in the days when it wasn't cool to work on burnout. And I was in that stage, and boy, was it uphill. The culture is strong.
Yeah.
And also the feeling that there's no limit to the brain power, and the fact that they're tired and they're up all night shouldn't affect your quality and safety. Where I don't know where we got that image from, but part of it is our medical culture, especially as things have expanded. We really are having a hard time doing that safely nowadays. And if you think about the 14% reduction, we already know the research and how that converts to patient safety and the economic benefits. The study in surgeons, high burnout was associated with a 200% increased risk of medical error. So the benefits of the reduction are clear just by looking at correlations with the research.
Absolutely. So, when you brought this and you did this work, what role did leadership and what role can they play in addressing some of these challenges? So the leaders who are listening, what can they do to really engage in this?
Okay, great questions. And part of what I've been doing for the last 14 years or so is trying to extract from human factors engineering, putting it into words that might make more sense to a layperson, because we're not engineers in healthcare. That's been the process. So basically realizing so many things from disparate authorities come through the C-suite, the CEO, chief financial officer, chief operations, et cetera, and realizing that is the opportunity for how we implement. How do we implement mandatories? How do we implement requirements? It usually gets dispersed to many different offices. The whole idea of, from the human factors point of view, is trying to get an idea of what are all the expectations going out. And that's where connecting well-being with quality work, you start to see that these are all interacting. If you understand what's happening to our brain, there's no doubt all this overload is affecting patient safety and quality. Plus, it's the unspoken reason why people keep leaving. So basically trying to get an idea of acknowledging that this cognitive load is a real thing. And the more we start to understand it, trying to understand in leadership positions some of the basics of what this means in terms of cognitive load. A great work that has been really instrumental in me understanding what to do in healthcare organizations is by William Passmore. Two really great things is Designing Effective Organization, the Socio-Technical Systems Perspective. That's a book he wrote in 1988. He kind of did predict our current situation by not dealing with the balance of people and technology. Right now, we're in the process of kind of buying tech, and we're finding that the people adjusting to all those learning curves or how they interact kind of get in the way of process. People know how to take care of the patient. They can't make it happen through the tech or other things like that. So realizing these are real things, the more we know about it. Taking on halo bias is another. Halo bias is something, because it might have a term, patient safety or quality, associated with it. We don't push back on the science. It already gets in the door because it's got that term. My point is, when you see if they're coming and there's so many of them, maybe it's not quality or safety anymore. Maybe it's actually doing the reverse and it's causing a problem because it's all totaled together. Understand how and where the impact is being felt. So that's feedback systems. Try to get feedback systems from front lines back to leadership, frontline to leadership. The way we're structured now, there's a communication flow. National, state, industry leadership and requirements go through the C-suite down to clinicians. It's mostly a one-way communication. We don't have feedback systems, and they're really critical. So the more we can do about getting more regular surveys, the psychosocial safety that's needed for being able to speak up if there's an issue is critical. So that culture is really important. So actually, healthcare leaders have a big key in improvement. and they can really do a lot more than they know right now. So the more that we understand about human factors, I really believe it's a way out of our struggles.
Oh, absolutely. I couldn't agree more with some of the things you said. I think that building those feedback loops give you so much opportunity to understand, because you don't know until you walk in someone's shoes to some extent or get their feedback, what it is to be them and to do their job. And we keep adding, and in healthcare tend to be a little bad at taking things away.
Yep.
And de-implementing. I know that's one of Krasinski's favorite words, and I love to use it. But how do we de-implement some of the things that we've put in place? Well, Mike, you have been really just such a shining light on this issue. I know you're, at least for me, you were the person who explained it to me and helped me understand it. And I just want to thank you so much for sharing your expertise, your experiences, all of the work that you've done over the last 14 years trying to figure out how to make us a kinder, gentler, and safer place to work, and continuing to do it, even though you're, enjoying a well-deserved vacation. But thank you again for joining me and sharing just a little bit about the work that you've done. If your organization has not signed up with the AHA Patient Safety Initiative, I absolutely encourage you to join us. You can gain a wealth of information and resources and collaborative opportunities and get to talk to people as awesome as Mike. So please sign up on the AHA Patient Safety Initiative webpage. Thank you for listening, and I hope you have a wonderful day. Thanks again, Mike.
Thank you, Elisa, for your continuing support.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.